So, very warm good evening to all of you. My name is Dr. Batsalya Anand. I am the newest one here, I think, and I am going to present some interesting cases of endoscopy. First of all, I want to thank all of you for coming here, getting time from your busy schedule. From busy schedule, I am reminded of a story that one fine evening I was with my family having a dinner with my wife and my 3-year-old beautiful daughter, and suddenly a phone call came to me, and they from my emergency, and they said that a 2-year baby boy has swallowed a coin, and they told me that baby is fine, baby is asymptomatic, there is nothing to worry. And I told okay, we will plan endoscopic removal tomorrow morning if it does not pass out on its own. But then immediately, then again a call came back to me, and they said that the patient is fine, but the baby is having drooling of saliva. So saliva is drooling out. So I told them to get an X-ray done immediately and just prepare for emergent endoscopy. So this is this X-ray image, and we can see the coin stuck here in the upper part of esophagus. So we did endoscopy immediately in the night, and we removed this coin immediately after, and baby was fine, everything was fine, and so we were all happy ending. Then incidentally, just 1 week after, again I was having a dinner with my family at a restaurant. Again a call came, and they said this time the baby was, again a baby has swallowed a coin, and this time the baby was of a OT nursing staff. He was a single male child of a single mother of OT staff, and the mother was crying and pleading for help. So I told them again, they told me that patient is asymptomatic. I told them to get an X-ray done and prepare for emergent endoscopy. It was in my mind that we will need an endoscopy again. They said the patient was completely asymptomatic. We prepared for endoscopy. I sat down in my car, and at that time the X-ray was done, and the nurse was at that hospital only, and so she immediately get her the baby's X-ray done, and she sent me the pic of this X-ray image. And what I saw that this time the baby has not swallowed coin. This time the baby has swallowed disc battery. So those of you who don't know, disc battery can be severe. It can cause severe complications, like it can cause necrosis and perforation in esophagus if it stayed long. So that is an emergent indication to get it out. But the X-ray which I have seen, the X-ray showed that it has reached. Sorry. So the X-ray showed that it is in the. It felt like it is in now past the esophagus, past the stomach, and now is in somewhere in the lower part of abdomen. So in endoscopy we can see, upper GI endoscopy we can see up to second part of duodenum, and this seemed to be out of reach from second part of duodenum. And so I said to the mother that we should wait, and we should give laxatives to the baby, and we should wait, and it should pass out on its own. Being a single mother and having a single giant male child, she was obviously very much distressed, and she was not happy with my decision. She was pushing me that no, you come, you do endoscopy. I went there, but I told her we don't need an endoscopy right now. Patient will be fine, baby is asymptomatic, we don't need an endoscopy, it should come out. They are saying that no, the family was insisting that get an endoscopy, see whatever place you can reach and try to pull it out. So then finally we convinced the baby ki, we convinced the family ki we should not do endoscopy unnecessarily and we will wait. Then next day we get again an X-ray done of abdomen, and this time the battery was here near ileocecal region. So again the family was insisting ki, I told ki we can remove if it remains there, we will remove it by colonoscopy, and by doing colonoscopy we can reach terminal ileum and from there we can remove it, but we should wait, it should pass out. Family was again ki no, better to take it out than to wait. I said ki no, we will wait. Then one day we again waited. We get baby was given lots of laxatives and their homemade remedies like bananas. Baby was 3 years old, so he was continuously fed with bananas. Lot of bananas he ate. I don't know how many they have given. And then we again get an X-ray next day done, and the third day the battery was here near rectal area. So again they were saying that now that this has come down, you go inside and you take it out by proctoscope or cimatoscope. I said no, we will wait. It should come down. Now it has reached this far, it should come down. And luckily next day in the early morning the mother happily sent me this picture with this. They were always searching in the stool with a stick what is happening, and they found this battery came out finally. So, just in the first case, as I was mentioning, first case, it was looking like patient is asymptomatic, but since he was having 2 years, baby cannot tell their symptoms, and he was having a sign of drooling of saliva. So this is an emergent indication because it is causing esophageal obstruction. In this case, we need to get an emergency endoscopy, and in this scenario, where it has passed this was the first X-ray where where the foreign body has where the foreign body has passed already. So here we have to wait. So there are certain emergent indications for foreign body removal, and there are certain urgent and certain non-urgent indications. I am not going into very much detail. This is by American Society of GI Endoscopy guidelines, and emergent endoscopy. The patients with esophageal obstruction, we need to get an emergent endoscopy as soon as possible. Within 6 hours of obstruction, and this batteries, if it is present in esophagus, we need to get it out in emergency. And if it has passed out in stomach or anywhere else, we can wait unless it passes out on its own. At least we can wait to 24 to 48 hours safely. So just to mention that in the first case was looking like it needs to not to be done in emergency, but we had to perform it. And the second case it was looking like we need to do because the mother was a nursing staff. She did her own research and googling and discussed with other doctors, and she came to know that lead batteries can cause perforation and necrosis. So she was in fact, I got to know she has researched because she was telling to me only by on call it can cause necrosis it can cause perforation and I was telling her you have read it on Google, but keep it under control. So like in life, same in endoscopy, sometimes we have to hold tight and sometimes we have to let go. So this is the core message. Thank you.
अगर आपको पता नहीं होता कि उसको डिस्क बैठती है तो क्या करते हैं?
सर अगर ऑब्स्ट्रक्शन नहीं है जैसा कि इसमें है, एक्सरे में वैसे हमें दिख रहा था, उन्होंने बताया भी था कि डिस्क बैटरी है, लेकिन अगर जैसा कि अगर if patient is having esophageal obstructions or we know disc batteries or sharp pointed objects is there, we need to get an urgent emergent endoscopy. if it is showing in X-ray and it is showing beyond the it is showing beyond the reach of endoscope, so we can wait in those cases.
इसका मेडिको लीगल इम्प्लीकेशन क्या है? 24 घंटे में भी कोरोजन हो सकता था, आप वेट करा रहे हैं उसको तो दिक्कत हो सकती थी ना?
Sir, it can, but it is in the guidelines it is clearly stated that once the object passes out esophagus, it can generally pass out in 85% of cases it can pass out spontaneously. So we can wait for 24 to 48 hours.
We can wait for 48 hours.
48 hours.
We can wait easily, no complications.
Yes, sir. Yes, sir. We can wait once. So for like this, if coin in esophagus, if there is no patient is asymptomatic, we can wait for 12 to 24 hours. In object in stomach with diameter more than 2.5 centimeter, we can wait. These batteries and cylindrical batteries that are in stomach of patients without signs of GI injury may be observed for as long as 48 hours. Batteries remaining in stomach longer than 48 hours should be removed. So for 48 hours we can give, but we should also look for the signs of any stomach injury or any GI injury. We should also be looking, like I was also saying, see whether patient is not having any pain abdomen, not having any vomiting, not having any difficulty, he is moving. If patient will having any difficulty, at least his or her activities will reduce. So he was normal at home. So we can wait in these scenarios.
What are the other weird things you have removed through endoscopy?
Ma'am,
Especially in children.
Ma'am, children, we have removed many things, but most of cases, most people haven't seen, but we have seen multiple worms in children. So we have removed many worms from children. So ingested or in duodenum, they are moving freely. Means children are having pain abdomen again and again. All the foreign bodies, ma'am, most of common is coins. Mostly they are coins, most commonly. And in young adolescents, we have removed chicken bone. So a young female came to me. She was 16 years old, and she ingested chicken. And while eating chicken, she had a bone of leg piece, small leg piece, stuck in her throat. So that we have removed.
Children also consume mommy's jewelry items.
Mother's jewelry items can consume, yes. Sir must have seen, sir is so experienced.
The size of a foreign body which can clear the ileocecal junction.
Sir, it is not. It is difficult to say. It is said that anything less than 2.5 centimeter can easily cross, but it depends on the patient size also, as well as the both height and width of the object. Sometimes a object which is length is big but it is slender, so after the gut tries to remove it via peristalsis. So even that is body tries to align it and tries to remove it. It means like if it is a length is like of this means 7 centimeter or 10 centimeter, but if it is thin, it can also crosses the IC wall.
10 rupee coin past the ICG.
Can yes sir.